I would like to invite Dr. Ronnie George for his presentation. Is the lens the real culprit in PACD? If so, is clear lens extraction a remedy? Sir is the head of glaucoma services, Shankar Nethralaya, Chennai.
Thank you. Thank Dr. Girija and KSOS for the invitation. And I've been asked to speak on how the lens, whether the lens is a real culprit in PACD. So I'll try and answer two questions. One is how much does a lens contribute to PACD? And also we'll discuss briefly the rationale for clear lens extraction that is currently postulated. So I'll just come to biometry first. So this is data from the Chennai glaucoma study. What we did is we looked at axial length, anterior chamber depth, and lens thickness. And we divided them into 10 equal groups. So 10 deciles of measurements. So this is the axial length data, and what you have is the shortest axial length on the left side and the longest axial length on the right side. And you have the proportion of angle closure disease in each of these deciles. And you can see quite clearly that about 65% of people in the shortest 10% of eyes had some form of angle closure disease. But you also had some angle closure disease even in the longest eyes. If you look at anterior chamber depth, again very similar numbers. So you're seeing in the shortest 10%, you're seeing almost 90% of the eyes with the shallowest anterior chambers had angle closure as compared to maybe 10% of the deepest eyes. But when you look at lens thickness, the picture changes a little bit. You have two peaks. One peak is in the eyes with the thinnest lenses, and one peak is in the eyes with the thickest lenses. And you also have some floating around in between. So this is a little unusual because you would expect thicker lenses to all have angle closure and the thinner lenses to not have. So then we tried to see whether the relative lens position, or the position of the lens relative to the length of the eyeball and the anterior chamber depth, that's calculated using this formula. What happens once you factor that into the equation? And once you factor that into the equation, you again see the same sort of picture, that the eyes with the most anterior relative lens position were most likely to have angle closure as compared to eyes with the most posterior lens position. So what this tells you is that the lens does play a role, but it is not a consistent role. The role of the lens is dependent on the size of the eyeball and the crowding of the anterior segment. So knocking off the lens in everybody just doesn't make any sense because this is the way it looks. So then I'll switch to this study, which looked at the quantitative evaluation of anterior segment parameters using ASOCT to look at primary angle closure mechanisms. So what they did here was they took ASOCT images and they divided them into 4 mechanisms of primary angle closure: pupillary block, which is this one, Plato iris configuration, thick peripheral iris roll, and the fourth is the lens vault. And based on this, they measured many things, but what we are really interested in over here is the lens vault. And this is what they found. They found that 33% of eyes had an exaggerated lens vault. The rest were other mechanisms. Pupillary block was about 30%, Plato iris and thick peripheral iris was the other 30%. And you can see from this is a graph which shows the lens vault in each of these conditions. You can see the eyes with an exaggerated lens vault had an average of more than 1.2 millimeters as compared to the other groups which were around 0.7, 0.6 and 0.5. So definitely when you look at this picture, looking at the anterior segment OCT and trying to see which form of which of these is contributory, just about a third of these eyes you're seeing the lens as being the primary force. You have another paper, and this first paper was from China. The second paper is from Iran, and in Iran they again they found that about 25% of patients, the primary cause was suspected to be the lens vault, and it was a secondary cause in addition to pupillary block and Plato iris in another 10% of patients. There's a third paper which saw what happens to these parameters once you finish the YAG laser iridotomy. So these two studies that I showed you are untreated eyes. So once you treat, what happened? They again divided them into these 4 categories. And what they found was that once you divided it like this, just 4 out of the 118 eyes were actually, or 3% of the eyes were actually lens vault. The rest were fitting more into the other mechanisms. But there are 2 caveats here. One, that this paper last paper was from a Polish population, which is Caucasian. The other populations were either Asian or Iranian. And the literature from the Asian population generally tells you that the lens vault is between 70 to 35% of the population is the lens is the primary, is significant, the lens vault is significant. So do Indians behave like Asians or Caucasians? And that's an interesting question. And there is this paper out of Singapore published some years back. And they looked at the rates of acute angle closure in Singapore as a city. And they found that the highest rates of acute angle closure was among Chinese. The second highest was among Malays and Indians. So Indians don't come close to the Chinese eyes. We are more closer to the Caucasian eyes when it comes to the way that our angle closures behave. And most of us over here don't see acute angle closure as commonly as our Chinese colleagues do. So going back to the study from the first study from Asia that I showed you, that also had a few Indian patients. Not many, about 15 patients or 10% of the patients were of Indian origin, and none of them had an exaggerated lens fault, as compared to about 1/3 of the Malay patients and as compared to more than 30% of the Chinese patients. So it's a very small number, but among those 15 Indian patients, nobody had an exaggerated lens fault. Keep in mind also that the lens fault became significant in the eyes with the shortest axial lengths. So this group had the shortest axial length in all the other three types. So is the lens the real culprit in all PACG? Not really. So what are the numbers in India where it's significant? I don't know. Maybe 20%, maybe 15%, but not more than that. And we still have no information as to how it changes post LPI in these eyes. Because if there's a pupillary block component also, you might see a improvement in the lens configuration. So I'll just briefly talk about the EAGLE study just to tell you two things. One was it was for PACG and for severe PAC, that is IOP more than 30. And they wanted to see what happened with intraocular pressure. And at 5 years post YAG-PI, they had a marginal change in intraocular pressure of 1.2 millimeters of mercury. And there are multiple factors that they looked at, but keep in mind that the differences that they saw were pretty small. In fact, in PSC alone, they did not find a difference. In PACG, they found that lens thickness improved. This is the combined data that they published, but if you look at the graphs, that's what you will see. And most importantly, they did not publish any gonioscopic data on what happened post LPI. And what I have shown you in the last three papers is that YAG-PI makes a difference to the configuration post once you do the procedure. So if you don't know what happens post YAG-PI in our eyes, it's very difficult to say that the lens is the culprit. So is lens extraction a remedy? Clear lens extraction, definitely not for all PACD. May have a role for a small number of people if you have a very narrow angle after YAG-PI, which is persistent, which is increasing Sin K, or if there is uncontrolled intraocular pressure with medications. To my mind, these are probably the only indications where I would even consider a clear lens extraction, because these are also the eyes where you're most likely to have a problem with cataract surgery. Thank you.